Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Yeah. What is a specimen? Hadia is all well prepared. Huh? Very good. Excellent. Zeba is also very nice. Answers very nice. Vagatika, very good. So fast, huh? Sujata, very sincere student of mine. Very nice. Great. Very good. Excellent, Hadia. Very nice. Sujata, everyone very nice. You describing it. Actually, there's not much to be described here. Whenever you have specimens of the fetuses, it's not much to be described, right? But hydrocephalus, yes, there is. Yeah. Great. So yes, the specimen shows conjoined twins, a rare congenital abnormality. This I'm going to be skipping. The specimen appears to be thoracopagus. With that, we'll come to later. The twins actually are joined at the thorax. Possibly they are sharing a vital organ like heart or liver or diaphragm. The fusions appears symmetrical, indicating equal development. Yeah, you see that is also very important. Both of them are equally developed, and none of them is fat or thin or overweight, underweight, nothing like that, right? So then, of course, the specimen shows conjoined twins joined together at the level of thorax, probably sharing a vital organ like a heart or diaphragm or liver. Yes, very important. What is the embryological cause of twinning? It's the incomplete splitting of a single fertilized egg between days 13 and 15. Remember, I told you it is like 3, 6, 6, 9, 9, 15, 9, 9, 12, and 13, 15, right? So you have DCDA, MCDA, MCMA, and then finally conjoined twins. Remember the 3 is stable, right? So it is 13 to 15. If they do not split or they split so late, 13 to 15, then probably they'll be having a conjoined twins. What's the most common type of conjoined twin? Thoracopagus is the most common. What imaging modality is the best? MRI is best to find out the complexity that they are sharing. Ultrasound will screen. It will also be able to tell you a little bit more that it's sharing what all, but MRI will be able to decide whether it is operable or not, whether we'll be able to save the twins or not, whether we will be able to compromise which twin to compromise if at all you're saving one, so on and so forth. So the finer details are given by MRI. The gross details are given by the ultrasound. Why is surgical separation of thoracopagus very difficult? Because it probably would be sharing vital organs. And what are the main ethical concerns in managing conjoined twins? Viability of both twins post-separation, quality of life that you're giving them, parental decisions are all ethical concerns, right? Okay. Are you okay with the next question or should I wait for you all? Are you enjoying, guys? Are you getting an idea how to speak on this? Because it's the only problem will come in speaking the initial few part. That will upset the examiner or that will impress the examiner. Rest of the Viva, they also know that you'll be able to. Okay, it's just the initial part. Great, Sujata. Very good. Thank you. Moving ahead, okay? Any doubts, please, you're free to ask during the class and post-class, no problem. What is this? Very good. Pragati, excellent. Hadia, very good. Yes, Zainab. Ziba, very good. I can't say posterior anterior because I can't see this thing round ligament. Round ligament decides anterior posterior, okay? Or the ovaries. This is how it is. Specimen shows a uterus with a large irregular tear on its wall, likely representing a case of ruptured uterus. The tear is disrupted, jagged, and hemorrhagic, suggesting complete rupture with exposure of underlying myometrium. possibly the endometrial cavity as well. Edges appear hemorrhagic, indicating severe trauma and probably hemorrhagic ischemic damage. The rupture site is commonly found in the lower uterine segment or along a previous cesarean scar. That is why we have it over here. Probably there was a cesarean scar which got completely avulsed. So this is, yes, you're right. This is a hysterectomized specimen of a uterus showing from now on you will pick, showing a tear, a large irregular tear in its wall through and through. See, can you see? A deep, large, irregular tear through its wall, which is disrupted, jagged and hemorrhagic, suggesting complete rupture and exposure of underlying myometrium, possibly the endometrial cavity. Okay, rupture site is commonly found in the lower uterine segment. Etiology, any previous scar on the uterus, a cesarean scar, uterine surgery scar, sometimes even in prolonged or obstructed labor, it can happen. Excessive oxytocin use or prostaglandin use, it can happen. Grand multiparity with prostaglandin use, it can happen. So, which is why we are so scared of the grand multis. And what are the clinical features? Usually the patient has sudden onset of severe abdominal pain and the loss of uterine contractions. Suddenly that you can feel the uterine parts are palpable, fetal distress and bleeding per vagina. Massive hemorrhagic shock, and it's an obstetrical emergency. So what is the most common site of uterine rupture? It is the lower uterine segment, previous cesarean scar area. What are two major risk factors of uterine rupture? Previous scar, any previous scar, prolonged obstructed labor also you can say, no problem. Then what is the gold standard management? Immediate laparotomy and resuscitation. Okay. Either uterine repair or a hysterectomy, depends upon the severity. Okay. Then how can uterine rupture be prevented in high-risk pregnancy? Avoid trial of labor. Proper labor monitoring, very important. Prevent hyperstimulation. This is looking like a scar rupture only, beta, because it's there at this point. Usually, if you have a fundal tear somewhere over here, it is most probably because of prolonged obstructed labor or what do I say? Prolonged labor or obstructed labor will have somewhere on the fundus, because that's the place at which the uterus thins out a lot. This is the place usually will have where you have a previous scar. Sometimes it gives way at very irregular ways, and this kind of scar can be very dangerous because it will go inside the broad ligament very easily, and then you will not be able to find out exact place of origin of the bleeding. Then we were here. What is the most dangerous maternal complication? Hemorrhagic shock. How can uterine rupture be prevented? Yeah, avoiding trial of labor in previous classical cesarean section or previous myomectomy or inverted T is very dangerous. Proper labor monitoring. I will not say avoiding trial of labor, but be very, 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 very careful while trying a labor on patients with a uterine scar. Proper labor monitoring, okay, to prevent hyperstimulation, elective repeat C-section, high-risk cases. Okay, guys? And with that, I finish my class today.